Welcome to our first video on liver cysts and malignancies. Let's begin. In this lecture, we'll discuss cavernous hemangioma, hepatic adenoma, and focal nodular hyperplasia. For each condition in this lecture, we will talk about the definition, risk factors, clinical presentation, diagnosis, and management. Let's start with cavernous hemangioma. A cavernous hemangioma is the most common benign tumor of the liver. It's composed of endothelial cells covering blood-filled spaces. Risk factors for cavernous hemangioma are related to high estrogen states. This is because estrogen can cause proliferation of hepatic vessels. First, female sex predisposes to the development of cavernous hemangioma. Additionally, pregnancy increases the estrogen levels. Therefore, they increase the risk for cavernous hemangioma. Von Hippel-Lindau syndrome is a neurocutaneous syndrome characterized by hemangiomas in multiple organs, including the liver. Cavernous hemangiomas are typically asymptomatic. They may also present with right upper abdominal pain and nausea if the size of the cavernous hemangioma is more than 4 centimeters. Let's briefly review the complications of a cavernous hemangioma. Since a cavernous hemangioma consists of blood vessels, it's prone to rupture and hemorrhage. Additionally, it may obstruct intrahepatic ducts, causing obstructive jaundice. Obstructive jaundice typically presents with dark urine and pale stools because direct bilirubin ends up in the urine rather than the intestines. Let's talk about the diagnosis now. Ultrasonography is the best initial imaging test for cavernous hemangioma. It typically shows a hyperechoic, homogeneous mass. Alternative imaging modalities in case of indeterminate ultrasound findings include contrast CT and MRI. It's high yield to remember that the biopsy is contraindicated for cavernous hemangiomas because there is a significant risk of hemorrhage. Let's see what a cavernous hemangioma looks like on a CT scan. On contrast CT image, the cavernous hemangioma is characterized by peripheral nodular enhancement during arterial phase. Centripetal filling is seen during the venous phase. Here is an ultrasound of the liver in a patient with a cavernous hemangioma. The cavernous hemangioma is the hyperechoic, homogeneous mass indicated by this large white arrow. Why is a biopsy contraindicated in a patient with cavernous hemangioma? The reason why biopsy is contraindicated in a patient with cavernous hemangioma is the risk of severe bleeding during biopsy. The definitive diagnosis of cavernous hemangioma requires multiple imaging modalities such as hepatic ultrasound, CT, or MRI. As far as management is concerned, if the cavernous hemangioma is asymptomatic or less than 4 centimeters, then management is simply observation with serial ultrasounds. However, if it's symptomatic or greater than 4 centimeters, then surgical resection or arterial embolization can be done. Arterial embolization will occlude the blood vessels feeding the cavernous hemangioma. Therefore, the mass will decrease in size due to decreased blood flow. Now let's talk about hepatic adenomas. A hepatic adenoma is a rare benign tumor of the epithelial cells of the liver. Hepatic adenomas are most commonly found in women of reproductive age. Other risk factors for hepatic adenomas include oral contraceptives and pregnancy. This is because hyperestrogenic state can induce proliferation of hepatic epithelial cells, leading to a hepatic adenoma. Anabolic steroids are also associated with the development of hepatic adenomas. When it comes to the clinical features, patients with a hepatic adenoma are typically asymptomatic. However, if the tumor gets big enough, it may cause right upper abdominal pain, fullness, and/or nausea. Even though a hepatic adenoma is considered to be benign, it can rarely undergo malignant transformation to hepatocellular carcinoma. A hepatic adenoma can also rupture. Rupture of a hepatic adenoma presents with abdominal pain and distension, along with the signs of peritonitis like abdominal rigidity and rebound tenderness. Isolated bleeding can also occur. In the case of bleeding or rupture, the bleeding can be so severe that it may lead to hemorrhagic shock. Upon clinical suspicion, the diagnosis of hepatic adenoma usually begins with imaging. The most commonly used initial imaging study is ultrasonography, which may reveal a single or multiple hyperechoic lesions. Contrast CT scan may show early peripheral enhancement. An MRI with hepatocyte-specific contrast agent is the best modality for the definitive diagnosis of hepatic adenoma. Hepatic arteriography can also be performed. Biopsy is avoided due to the risk of bleeding. This is what a hepatic adenoma looks like on ultrasound. Please note this solitary, solid, hyperechoic mass in the right lobe of the liver. This appearance is characteristic of hepatic adenomas. A 25-year-old woman comes to the physician due to right upper abdominal pain. She has been taking oral contraceptive pills since the age of 15 for endometriosis. Right upper quadrant ultrasound shows a solitary, solid, hyperechoic hepatic mass. What most likely predisposed the patient to the development of her current condition? This young woman with right upper abdominal pain and history of long-term use of oral contraceptive pills has a solitary, solid, hyperechoic hepatic mass on the ultrasound. This description is consistent with the diagnosis of hepatic adenoma. The patient's long-term use of oral contraceptive pills is what most likely predisposed her to the development of hepatic adenoma. If the patient is asymptomatic or the tumor less than 5 centimeters, conservative treatment such as discontinuing oral contraceptive pills or anabolic steroids is usually enough. Imaging should be repeated in 6 months to monitor progression of the tumor. There are several indications for surgical resection of a hepatic adenoma. Male sex is an indication for resection regardless of tumor size. In women, adenomas larger than 5 centimeters should be resected due to the high risk of malignant transformation. Surgical resection is also indicated in patients with bleeding or rupture. An important part of management is following up with imaging such as CT or MRI in 6 to 12-month intervals to ensure that the tumor has not returned. Lastly, let's move on to focal nodular hyperplasia.
Focal nodular hyperplasia is the second most benign tumor of the liver.
FNH arises as a result of hyperplastic responses to hyperperfusion that is caused by an inappropriately large artery. This large artery is typically found at the center of the lesion. Focal nodular hyperplasia most commonly arises in women of reproductive age. However, in contrast to hepatic adenoma, focal nodular hyperplasia is not associated with oral contraceptive pills. Focal nodular hyperplasia is usually asymptomatic. However, it can result in right upper abdominal pain if it's large. Additionally, a palpable abdominal mass may be observed on physical exam. Let's talk about the diagnosis now. Ultrasonography classically reveals the central arteries with a spoke wheel appearance. A contrast CT, on the other hand, shows a central stellate scar. In addition to ultrasonography and contrast CT, MRI can also be performed to diagnose the focal nodular hyperplasia. On MRI with liver contrast, the lesion will initially appear hyperintense. Then, as the contrast diffuses to the center of the mass, the central scar becomes more evident. Finally, biopsy can confirm the diagnosis. This is an ultrasound image of focal nodular hyperplasia. Please note this isoechoic lesion with radial arrangement of the vascular supply. Let's take a look at the CT scan of a patient with focal nodular hyperplasia. Here, one can see the central area of hypodensity, often referred to as a central scar. Around the central scar, there is enhancement of the lesion from focal nodular hyperplasia. This is the characteristic appearance of focal nodular hyperplasia on CT scan. Asymptomatic focal nodular hyperplasia can be managed with observation using serial ultrasounds. In contrast, symptomatic lesions require surgical resection. How can focal nodular hyperplasia and hepatic adenoma be distinguished from one another on imaging? In focal nodular hyperplasia, a CT scan typically reveals a central stellate scar with peripheral radiating trabeculae. In contrast, the CT scan of hepatic adenoma shows a well-demarcated hyperechoic mass with early peripheral enhancement. Here's a table summarizing all the conditions we talked about in this lecture. Pause the video and take a moment to consider this table. A 32-year-old man comes to the physician due to dull right upper abdominal pain for 8 months. He is a wrestler and he has been using anabolic steroids for 5 years to increase his stamina. He drinks 4 bottles of beer every night. His vital signs include a temperature of 36 degrees Celsius, blood pressure of 135/80, heart rate of 65, and respiratory rate of 13. The physical exam reveals the right upper quadrant tenderness without rigidity. The ultrasound shows a well-demarcated hyperechoic mass. The contrast CT scan reveals early peripheral enhancement. Which of the following is the most likely diagnosis? A. Cavernous hemangioma. B. Hepatic adenoma. C. Focal nodular hyperplasia. Or D. Hepatocellular carcinoma. This 32-year-old man presents with dull right upper abdominal pain for 8 months. He is a wrestler and has been using anabolic steroids for 5 years to increase his stamina. The physical exam reveals a right upper quadrant tenderness without rigidity. The ultrasound shows a well-demarcated hyperechoic mass. The contrast CT scan reveals early peripheral enhancement. This description is consistent with a hepatic adenoma. His hepatic adenoma is likely induced by prolonged use of anabolic steroids. So the correct answer is option B. Again, here's the table summarizing all the conditions we talked about in this lecture. Pause the video and take a moment to compare and contrast these conditions. Let's discuss why other options are incorrect. Option A, cavernous hemangioma, is incorrect because although it is characterized as a hyperechoic homogeneous mass on ultrasound, it is not accompanied by early peripheral enhancement on contrast CT scan. Option C, focal nodular hyperplasia, is incorrect because on the ultrasound it is characterized by central arteries with spoke wheel appearance. This sign is absent in this patient. On CT scan, it shows the central stellate scar, which is also absent in this patient. Finally, option D is incorrect because although this patient has extensive alcohol exposure, hepatocellular carcinoma is very unlikely at his age. And that concludes our lecture on cavernous hemangioma, hepatic adenoma, and focal nodular hyperplasia.